afternoon, everyone. It's a pleasure to be here with you. Let me talk about our project of rheumatic heart disease in Aswan. I won't tell you too much about the background of rheumatic heart disease, but it starts with rheumatic fever, which is caused by group A streptococci as well as group C and G, as lately shown in different microbiological studies. There is a geographical variety in the strains and their rheumatogenicy, and the prevalence of subclinical rheumatic heart disease is as high as 90%. Rheumatic heart disease affects mainly, predominantly the mitral valve, but other affections are also possible. The pathogenesis is complex and involves both microbial as well as host factors and, of course, the strain itself, the streptococci. Let's skip the map, we have seen it. In Aswan, we have performed the systematic cross-sectional screening of school children. There is Aswan. Let me see. There it is, Cairo, or capital. We have seen 3,062 children chosen randomly, which is representative of 6% of the school children in the area. We have chosen the age group of 5 to 15 years old, and the randomization was performed in 3 stages, by randomizing by area, school, and age, and as well depending on the amount of children representative for the area. We have chosen 7 areas in Aswan. This is the whole city. Sorry, let's go back. And these are the 7 areas chosen, in which in every area we have chosen 3 schools, so we could achieve the 3 age groups, 5 to 6, and then 6 to 12, and then 12 to 15. The screening included a questionnaire on demographics, cardiac auscultation, and transthoracic echo. Transthoracic echo was a normal performable echo, parasternal long axis views and short axis views with apical 4 chambers and 2 chamber views, so we could revise the morphology and the structure of the valves. Our criteria, the criteria we have used was, we have tried to keep it simple, any degree of regurgitation of any of the valves with at least one of the structural affections, which was the valvular thickening, dooming of the valvular cusps, fusion of subvalvular apparatus, or leaflet shortening, or any degree of isolated stenosis. So a combination of functional with a structural affection of the valves led to a definite rheumatic heart disease diagnosis. If we found only isolated valvular thickening or isolated leaflet restriction or isolated at least mitral regurgitation, then we thought it was a possible rheumatic heart disease case. We have compared our criteria with the WHO criteria, and if we take a fast look, the biggest difference between our criteria and their criteria is that the WHO only looks at regurgitation. It doesn't look at any stenotic lesions, and it totally ignores any trivial affection of the rheumatic valves. When compared to another criteria which has been used, the biggest difference between our criteria and the carapitis is that carapitis starts with the mild affections, while we consider trivial affection as well an early sign of rheumatic heart disease. The criteria which looks most like ours is the Marjan's. It has been used before in the Cambodia and Mozambique study, and it looks at functional as well as structural affection, but then with a combination of 2 structural affections. Or the cohort study had a mean age of 10 years, and there was a slight male predominance, but wasn't very significant, and this is the age distribution. Rheumatic heart disease was diagnosed in 23 per 1,000 school children. So we had a total of 70 rheumatic heart disease cases in this cohort of 3,000 children. A murmur was found only in 5 children of the 70. So actually we have seen a 14-fold increase of a diagnosis when using an echo. There was a peak incidence in the 11 to 12 years old group, but it wasn't significant, and also a male predominance. This is the age groups by rheumatic diagnosis. This is the peak we see, but we see as well rheumatic heart disease affection as well in 5 years, 6 years, 9 years. So it wasn't significant. When looking at the group that was diagnosed with rheumatic heart disease, we found that 94% had thickening of the leaflets, especially the mitral leaflets, while the fusion of the subvalvular apparatus or the thickening of the subvalvular apparatus was less common, only in 1 case. And then the combinations were even less common. As we can see, this is an echo where we see a thickened tip and the starting of a dooming is still not very significant. And when looking at this, the most predominant affection was the mitral regurgitation, 96%, and then divided in trivial and mild affections, which is almost similar. Aortic regurgitation was much less common and it was mild. Combination of the mitral and aortic valve regurgitation was only seen in 1 child. If we put this in a graph, this is how it looks like. Mitral affection is predominant while aortic affection or a combination of aortic and mitral affection is much less common. Here we can see the regurgitation in one of the children, different jets. We have found 41 cases of possible rheumatic heart disease. These children had only isolated affection of the leaflets, and we thought that they were possible rheumatic heart disease cases. This led to a prevalence of 13.7 per 1,000 school children. Most of them had isolated thickness of the leaflets, while others had affection of their mitral valve. If we compare the criteria used in earlier studies, we can see that the Aswan Heart Center criteria, which is the one we developed, which is a combination of 1 functional and 1 structural affection of the valve, leads to a higher prevalence or a higher diagnostic rate for rheumatic heart disease. This is followed by the WHO, and it is much comparable to the Marjan. The carapatus misses all the trivial affection of the valves, which could be a sign of early rheumatic heart disease, and which could point to the children that still can benefit from penicillin prophylaxis. As we know, rheumatic heart disease is one of the most neglected diseases in the world, and it has a very large global burden, but it's still underestimated till date, and it is neglected even in the neglected diseases. The exact prevalence is poorly studied, particularly in Africa. There are no systemic echocardiographic studies performed, and our own study is the first systemic survey from the MENA region and the sub-Saharan Africa. We have shown high prevalence of rheumatic heart disease in Aswan, and in our own clinical experience, we see that 50% of the medical workload and 20% of the surgical workload of the Aswan Heart Center is composed of rheumatic heart disease cases. The prevalence we have shown of 23 per 1,000 is comparable to Cambodia, Mozambique, and Southeast Asia, which were performed with the criteria we have shown earlier. Why we have chosen for children between 5 and 15 years old? It's because they are the most vulnerable group, and it has been recommended through the WHO to perform screening in this age group, as it is a way to diagnose new cases which can still benefit from penicillin prophylaxis and study the prevalence and the factors which lead to development of rheumatic heart disease. Echocardiography has been shown to be the most sensitive and specific method for diagnosis of rheumatic heart disease. And as we have shown, the criteria show different diagnostic rates, but when composing the criteria with functional as well as structural features of rheumatic heart disease, I think we would be able to diagnose most of the rheumatic heart disease cases. This shows that there is a huge need for more systematic prevalence studies in different endemic areas, but the prevalence depends on the echocardiographic diagnostic criteria. So we should perform these studies with the same criteria so we could compare the results between different areas. Of course, there is the need for more understanding of the disease at cellular and molecular levels, especially when using biomarkers for the diagnosis of early rheumatic heart disease and for the diagnosis of rheumatogenic strains, so we can start early treatment. Currently, we have started a follow-up clinic for the cases diagnosed at schools in Aswan. We have seen 56 children for follow-up. We have retaken the questionnaire, taken the vital signs, ECG, laboratory exams, and echocardiography. This was around 1 year after the first diagnosis. And recently we have started a secondary prophylaxis clinic, so we can provide regular penicillin prophylaxis with a schedule of 21 days. So all children are provided penicillin prophylaxis, and they are given the next appointment, and whenever they don't show up for the next appointment, we contact the parents so they come back. Unfortunately, the compliance is very low, especially for the penicillin prophylaxis. We have two different types of follow-up, which is consisted of echocardiography and the secondary prophylaxis, and like 50% of the children do not show up for penicillin prophylaxis, even after regular calls and follow-up. So probably awareness should be one of the main targets for the prevention of rheumatic heart disease.